So with the permission of our faculty, I'm starting this program. Hope my slides are visible and I'm audible too. So good evening to everyone. I'm Dr. Onkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in this interesting session of updates on HIV guideline and illustrative cases. Today we have two eminent faculty who will be speaking on two different aspects of HIV medicine. And I hope this will be a very interesting and interactive session. We will learn a lot of new things and also most importantly, the case presentations at real life scenario. It gives me an immense pleasure to welcome and introduce our first speaker for today evening, Dr. Jehangir Sorabjee sir. So sir will be speaking on HIV from past to present. Sir has been an alumni of the Grant Medical College, Mumbai, and sir has worked in UK for 5 years at different hospitals and for his MRCP and DTMH from London. He has worked as an honorary consultant physician at Bombay Hospital from 1991 and currently working as a honorary professor of medicine and head of the Department of Medicine at Bombay Hospital Institute of Medical Sciences and postgraduate teacher at Maharashtra University of Health Sciences. Sir had also worked at Kasturba Infectious Disease Hospital, Mumbai as an honorary physician for 5 years and previously at the Hospital for Tropical Disease in London and Royal Free Hospital. Sir has been an examiner for MRCP UK and MD Internal Medicine at Maharashtra University of Health Sciences. Sir has also been an honorary physician to the Governor of Maharashtra and former member of Academic Council of MUHS. Sir has many publications on his credit and also authored many textbook chapters. Thank you very much, sir, being a part of this webinar. And your lectures would be really helpful for the larger audience who would be like to understand newer developments in HIV, which topics is HIV from past to present. Thank you. At the same time, I welcome our second faculty for today evening, Dr. Rajeev Soman, sir. He will be presenting some illustrative case discussions and real life cases. And that would be really interesting to listen from the senior expert like Dr. Rajeev Soman, sir. So sir has currently working as an infectious disease physician at Jupiter Hospital, Pune, and also Dinanath Mangeshkar Hospital in Pune. Sir has been a courtesy visiting consultant at a PD Hinduja National Hospital in Mumbai. Sir has been recipients of the Fellowship for the Infectious Disease Society of America and also work as a co-chairman of Fungal Infectious Study Forum. Sir has been an executive member of Clinical Infectious Disease Society. Sir had many textbooks and many chapters in the infectious disease, case books for invasive fungal infections and case book for the HIV medicine. Sir has been an editor for case book of COVID-19 too. Thank you very much, sir, being a part of this webinar. We look forward some interesting and illustrative cases from you. So at this point, let's stop here and go to our first speaker, Dr. Jehangir Sorabjee. He will be presenting first. Over to you, sir. Thank you very much.
Thank you. And I just, forgive me if I'm not very slick with my...
We can see your slides. You need to just make it full. Yes, yeah, absolutely.
Okay, am I all right there? Thanks, Dr. Onkar. It's a pleasure to be on a platform with Rajeev and the Emcure team again. And also, it's a pleasure to speak about something other than COVID, which gives us some indication that the tsunami is ebbing a little bit and we can turn our mind to other matters. I wanted to speak a little bit about experiences with HIV. A couple of days back, one of my patients came to me and said that I had been treating him for 27 years. I was a bit shocked and realized that, some of our patients are forced to keep coming back to us because of the fact that HIV is such a chronic disease for such a long period of time. Of course, he had to add that when I first came to you, your fees were only 300 rupees. So I say that petrol was only 10 rupees at that time. So it just shows us that, we've been in this field for a very long time. And what I thought I'd do is, take a kind of a revision class and say what we did in the past and where we stand just now. So the first question, of course, is that when someone tests HIV positive, who do we treat and when do we start? In the initial days, everything was focused around the CD4 count. And it was, if the CD4 count is less than 200, then treat. If it's 200 to 350, think about it. Then less than 350, then less than 500 became CD4 count driven, largely because of the fact that to treat was a big thing. You had the initial treatments, I remember, cost almost 35,000 rupees a month, consisting of three drug regimens with Indanavir, which was imported from the USA, 18 pills a day. So treatment tended to be deferred because it was poorly tolerated and people really required it as a kind of a rescue medication. But as treatment has improved and we've had so many single tablet regimes coming up, and the data has shown that there's huge benefit in treating people, even if they're asymptomatic, and even if they have good CD4 counts, as has been shown by the START study and everybody, and other studies, the trend has treated that everybody requires treatment. So if you're positive, you get treated, and you get treated successfully, and you do much better than if you defer treatment. What's trended even further and one stage more than that is now is treat instantly. That is, the day you test positive, you should be on that very day itself enrolled in some kind of treatment program, because otherwise patients tend to be lost to follow up. But that has its downsides, because the day that you want to start treatment, when you find out someone tests positive, you may not actually have all the data with which to give the correct treatment. But the trend has shifted completely from sort of a wait and watch approach 20 years ago to treating practically on the same day. And of course, it's what ART to start. I remember when I was in the UK and I saw my first patient of HIV 35 years ago, there was nothing you could do but treat the opportunistic infections, and that too not very well. And then after that, we were very excited about the fact that Zidovudine came. And Zidovudine was given as monotherapy, and we thought that there was some benefit. Then Stavudine came, and there was Zidovudine and Stavudine, but that wasn't enough. And then the triple therapy cocktails came. And now we are very used to the fact that we have triple therapy cocktails, but there's been good evidence, and the latest guidelines have also suggested that you could do equally well with two drugs and knock off some of the drugs, specifically the NRTIs, which tend to be particularly toxic and cause more side effects. Don't forget that as things stand now, if you treat someone with HIV, it's going to be indefinite treatment. So it's not just a question of somebody getting a few side effects in the first couple of months and then getting over it. We have to think about what's going to happen in the decades ahead as they remain on their treatment. And that's why we need to tailor treatment so that they don't get any side effects. So we've come from triple therapy, which is the standard, to the possibility of dual therapy. And monotherapy has been looked at, but hasn't been shown to be effective. So monotherapy with a single drug like dolutegravir or darunavir, which have high genetic barriers to resistance, has been tried as monotherapy, but shown to have a higher rate of virological failure than the use with dual therapy or triple therapy. So it's not recommended, but who knows? We may get something which is perfectly effective, and we may come back to one pill again. So here again, the journey has gone from one pill to 3 pills and 3 pills to 2 pills, 2 drugs. There's a pre-treatment checklist. In the early days, we used to just do the CD4 count and track the CD4 counts and say, come back again with another CD4 count for 3 months, 4 months. Viral loads were expensive, not easily available, and we knew that untreated patients would have high viral loads. Now, in addition to the CD4 count, the viral load is important, because the option of using certain regimes and certain drugs may not be as good if the viral load is high, more than 100,000 copies, more than 500,000 copies. So we do want to have a baseline viral load to figure out which drugs would work best. Hep B status, Hep C status are also important. And if you're considering using a abacavir, the HLA-B5701 is available and should be done. I can't tell you how many times I forget to do the HLA-B5701 and just give a abacavir, and most of the times you get away with it. But there are times when people have had bad hypersensitivity reactions, and it should be done when affordable and available. As far as childbearing potential is concerned, you have to consider whether drugs are safe in pregnancy or not. And the other interesting thing is that with the widespread use of certain regimes over the last 20, 30 years, there may be within the community a certain incidence of drug resistance, which is native to the population. In the Western countries where they've used a lot of NNRTIs and PIs, it may be as much as 10%, 15%. Ours may be up to about 7, 10% or so. And in those cases, in an ideal situation, you would want to do an HIV genotyping to figure out if the patient who is being started on antiretroviral therapy has any resistant virus or not. There is a caveat to that, and that is that most people who are not on antiretroviral therapy will revert to wild type virus, and even if they have archive mutations, it may not show up in the HIV genotyping. But transmitted drug resistant mutations tend to actually occur for a long time. So there's no harm in doing the genotyping. And if you pick up a drug resistant mutation, then you might want to alter your drug regime, the initial drug regime. But on the other hand, you know that if it's not there, it doesn't mean that it isn't archived somewhere and will express itself with treatment. If the patient has been previously treated, it's very important to figure out why he stopped treatment, what drugs he was given, and whether he took them regularly, and whether, again, there is a possibility of having resistant virus. And of course, over time, we've had to deal with opportunistic infections. These days, we don't see too many opportunistic infections. And whereas previously we'd see a lot of cryptococcal meningitis and PCP pneumonia, nowadays that tends to be relatively uncommon, and it wouldn't be unusual for our residents not to see more than 1 in 6 months or so. The issue used to be for us when to start the ART in patients with active opportunistic infections. And in early days, we used to defer it because we didn't want to burden the patient with a lot of medication and cause side effects, liver side effects or hematological problems, etc. But very good controlled studies have shown that as far as patients who have opportunistic infections are concerned, you must start the ART early. So even that question has been well addressed. And now, once we've started the treatment for the opportunistic infection and the patients have settled in on that medication within a week or two, we are starting ART almost immediately, with the exception of patients who have cryptococcal or tuberculous meningitis in whom you might get a bad iris and want to actually defer that for a while. So that's the way this has evolved. Most of the patients we have used treatment on in the last 20 years has been NNRTI regimes. And they've consisted of 2 NRTIs and 1 NNRTI, specifically using nevirapine and efavirenz. Nevirapine used to be used in the beginning because it was the only one available and it was much cheaper than efavirenz. But we landed up with a lot of problems with Stevens-Johnson syndrome, and you could get a drug-induced hepatitis, especially if you found that the CD4 count was more than 250 in women and more than 500 in men. So we had to withdraw the use of that drug, and it was given twice a day. Studies to show whether it could be given once a day were showed that it wasn't effective. So nevirapine sort of fallen by the wayside, and I don't think we've prescribed nevirapine for years now. Efavirenz has been actually a very solid warhorse, and it's really sustained us in managing our patients with HIV who needed ART for the last 10, 20 years or so. It's very robust. It has a low genetic barrier to resistance, but it is very tolerant of patients omitting it because it has high blood levels. And other than the fact that patients may have sleep disturbances and some neuropsychiatric manifestations in the first few days, they generally tolerate the drug fairly well, and we've used it quite well. But what's happened now is that the studies comparing efavirenz to many of the other newer drugs, dolutegravir, darunavir, etc., have shown that the others are superior, but largely superior because of the fact that people stop the efavirenz because they can't tolerate the side effects. And lower dose studies have been done. And I think Emcure also has a combined single tablet regime with just 400 milligrams. And the 400 milligram tablet has been shown to be equally effective at suppressing viral replication. There have been 2 studies done. Some have been a little small, but they have shown that even when you have a single tablet regime with 400 milligrams of efavirenz, which is combined with anti-TB medication or used in pregnant patients, drug levels are reasonably well maintained. So whereas previously we used to even think of increasing efavirenz from 600 to 800 if we used rifampicin, now it looks as if we can continue with 400. And it's possible that 400 milligram single tablet regimes of efavirenz will prove to be extremely robust, well tolerated, and the cheapest way to keep everybody on treatment and battle the HIV epidemic. The newer NNRTIs haven't come to India, and they probably are going to be useful because some of them, like doravirine, certainly can be given even in the presence of some of the resistance mutations to the older NNRTIs. The rilpivirine, the advantage of rilpivirine is that it's a very small tablet, and so it can be used, but it's got problems with food, it's got problems with the fact that you can't use it if the viral load is high or the CD4 count is low. And I suspect that some of these NNRTIs may not be used, the new NNRTIs may not be used as the backbone of a single tablet regime with two NRTIs, but may actually be used as an add-on to drugs like dolutegravir or darunavir, which have a high genetic barrier to resistance, in which you want to avoid the use of NRTIs. So you give one NNRTI, which is a newer one, and one of the drugs with a high genetic barrier to resistance. So that may be where I think these drugs will turn out to be useful, even though in the West they are available and used in single tablet regimes. Of course, the joy has been the INSTI regimes. And the main thing is that when do we use them? They're very well tolerated, they're single tablets, they are very powerful, they have high genetic barriers to resistance. So you find patients can go on with them for months, for years and not develop resistance, etc. Of course, I think all of us who have been treating HIV patients have always been very careful to preserve many of the newer drugs and keep them as reserve drugs, because we've always been felt that there's a paucity of medication and we wanted to keep powerful medications for later. So we would put people on the usual first line and keep these in reserve for people who only failed. But I think it's been shown that you're more likely to succeed and have sustained benefits from virological reduction and good ART if you use your best drugs first. So it doesn't really make sense to keep them in reserve. As an analogy, it would be keeping rifampicin for later and saying, no, I'll use only streptomycin and I'll use, thiacetazone and all the older drugs first, and only if that doesn't work, then I'll bring in rifampicin, etc. It makes much more sense to use your best drugs right in the beginning. The first generation INSTIs like raltegravir and elvitegravir had a low genetic barrier to resistance, and therefore you found that if people didn't take them well, they did tend to fail with virological failure. But the newer ones, dolutegravir and bictegravir, have high genetic barriers and they make drug combinations much easier. Also, many times we find that because these integrase stand transfer inhibitors are now available as single tablet regimes, it's much easier to switch people who have been on PIs for second generation for second line drugs into a single tablet regime back once again, because they're well tolerated and they are actually quite effective. So I'm finding that as time goes on, rather than struggling to find a regime which will give me good virological suppression, I'm finding it easier and easier to work it out with less use of genotyping, etc. Dolutegravir and bictegravir are two of these. They're single pills. They're combined with different NRTIs in the single tablet regime. High genetic barrier to resistance. There was an issue initially as to whether you could use dolutegravir in pregnant women, but that's been resolved and it's now been considered safe. Bictegravir, the evidence is not yet there, so it's not been recommended as yet. There is an issue with weight gain, and a lot of patients who are on these drugs have quite a significant weight gain. And trying out different regimes, whereas you might get a 2 kilo weight gain with efavirenz, you can get an 8 kilo weight gain with dolutegravir. But the clinical significance of that is not understood, and it seems to be more when dolutegravir is combined with TAF rather than TDF. There may be some neurological disturbances. In fact, there were some reports, I think, from Germany saying that a lot of people are coming off dolutegravir because of that, but our experience has not been that way, and it has been very good. Of course, there is also now the possibility of using it in a 2-drug regime with just lamivudine, but the question is whether the patient has got an M184V mutation, which would code for 3TC resistance. And therefore, before you started a 2-drug regime with dolutegravir and 3-TC alone, which has been shown to be as effective as a 3-drug regime, you need to do a genotyping to make sure that you're not missing that. What about the protease inhibitors? Currently, all the old ones have gone by the wayside. I don't know that they're even being made anymore. And the 3 which are being used are lopinavir, atazanavir, and darunavir. Lopinavir, I think, is used a lot in the government setting because it's available to them at low cost. The disadvantage is that it really has to be given twice a day. And when you give it twice a day, you use a bigger dose of ritonavir, and with that, you have problems with lipids and metabolic problems, etc. Atazanavir, the problem is that you keep on discovering that patients develop side effects. Most of them will have a little indirect hyperbilirubinemia, which shows up on the blood test, but may even show up as scleral icterus and jaundice at some times. They get kidney stones, they get gallstones as well, and they can even get some amount of renal dysfunction. Darunavir is by far the best, but the most expensive, and can be given once a day also in patients, and it's now combined with the ritonavir and available as a single tablet. But it has a slight disadvantage in as much as it's got more cardiovascular problems than atazanavir is, but I don't think that's very significant. So there are a lot of advantages and disadvantages. By and large, we turn to PIs now once we've run through the NRTIs, and once you're looking for something, the NNRTIs, and we're looking for something as a rescue medication. And very often I find that we combine darunavir with dolutegravir, and we get very good virological suppression in patients who've been on multiple regimes in the past. Now, as far as monitoring the patient on ART is concerned, the viral load is the most important. And patients who have been stable with suppressed viral loads for a long period of time really don't need a CD4 count, because all it does is cause anxiety to the patient. Because CD4 counts can vary 20–30% without any clinical significance, and patients keep getting upset because they feel that their CD4 counts have gone down and up, etc. And we have to reassure them really that a fully suppressed viral load is the most important. But because of the fact that patients are on treatment now for decades, and not just months, not just years, they do develop other problems, and we need to monitor regularly their renal function, their bone density, their lipids. And there's some thought that we might even be looking in the future at some inflammatory markers to see if we can get them under control. At present, it is not recommended that we do any of those tests. Of course, the thing about the reason you're doing all these tests is to find out whether your treatment is working or whether it's failing. And to figure that out, you need to look more at the viral load than the CD4 count. The question is that at what point of the viral load rising above a certain threshold do you feel that your treatment has failed and you need to actually switch and alter to somebody else? Most of us would keep looking at viral loads which are over 1,000 and say that, okay, you probably need to change. But many other recommendations come in at just about 200. The disadvantage, of course, is that between 200 and 1,000, you're unlikely to get a positive genotypic resistance test if you want one to actually find out what's happening, because you require at least 1,000 copies multiplying in the blood to produce enough virus for the test to give you all the mutations with which you can find out which drugs may work in the next regime and which may not work. So that test is useful. It requires a lot of interpretation. Then, of course, the treatment fails because of certain reasons. Most of the times it is because of adherence issues. Patients don't take the medicine. They're sometimes just fed up. And you can imagine that patients who've been asked to take their treatment for 20 years, 25 years, 27 years, as in this patient, they are going to get fed up. So that is one. Then, of course, there's the cost burden, and it can get further and further with newer regimes, which they will take initially, but once they feel better, they will stop. It's very difficult to convince people that they actually need to take this treatment continuously. And if they stop and restart, it may not work when they restart. There's often intolerance to drugs, which can be managed by tweaking the timing of the drug or some other symptomatic treatment, etc. But at some point with experience, you figure out whether you need to switch because the treatment has failed and try out a new regime. The drug resistance testing is really useful. And the important thing is to do it while the patient is on treatment, because that's the time the pressure exists to produce the mutations which code for the resistance to the drug. If you do it after the patient has stopped all the medication, within about 4 to 6 weeks, you may get full reversion to wild type virus, as a result of which you will not see the mutation. There are newer tests which we don't have in our country for HIV proviral drug resistance testing, which are very sensitive. but may not give you the complete answer. So with the caveat that it's not 100% perfect. If you pick up something, well and good. If you don't, it doesn't mean it doesn't exist. And if you're considering using Maraviroc, the older tropism assays have been shown to be faulty. And the newer ones, including a genotypic test, are actually the ones to go for. So as far as second line regimes are concerned, you want to use drugs with high resistance barriers, which are specifically the second generation INSTIs like dolutegravir, or the PIs like boosted darunavir, and you need to bring in a new class of drug. And largely on the basis of genotypic resistance testing, you can see what's available in the rag bag of NRTIs that you might be able to use. If the patients had tenofovir, you might be able to use zidovirine. If the patients had zidovirine, you may be able to use abacavir, etc. And address the issues for the failure of the initial regime. Because if you don't address that, and you just change the regime on an academic basis without trying to understand what are the circumstances for the failure, then you'll just get another failure to this next regime, and then you'll run out of options at some point. You need to monitor the responses also to the second line treatment and make sure that they're working adequately. The problem also occurs not commonly, but sometimes when there's a CD4 count and a viral load discordant, where the CD4 falls despite virological suppression. And it is quite confusing because theoretically, we are supposed to look for HCV, concomitant HIV2, or it's supposed to be the expression of some underlying malignancy or lymphoma which is cropped up. But sometimes you just cannot find anything. And whereas patients have completely suppressed viral loads, you may find that the CD4 count is going down, but generally they don't get opportunistic infections. And this is not an indication to change therapy, because either adding in new drugs and intensifying therapy or altering therapy doesn't necessarily lead to a rise in the CD4 count, and nor does giving interferon as boosters, etc. There's the worry about ongoing inflammation in HIV. And even though patients have full virological suppression, there's obviously some low-grade virological replication going on, which gives rise to an inflammatory state in the body. And some of these markers, which we've become very familiar with since COVID times, CRP, IL-6, D-dimer, etc., may be elevated. But as things stand currently, the significance of that is not understood, and there are many clinical trials going on to see whether addressing this separately will give rise to some kind of benefit or not. So the answer is don't do them, because you'll just land up not knowing what to do if they are elevated. The other thing which we've come to realize, which is really useful, is that treatment is one of the best ways of blocking transmission of HIV. ART is the most powerful tool, and early treatment and universal ART has caused a decline in numbers worldwide. And it's made it much more comfortable for serodiscordant couples to have intercourse without a condom, because we know from the studies that the rate of transmission in people who have stable, suppressed viral loads on ART for more than 6 months is almost impossible. Almost nobody gets an infection from one partner to the other if they have been well maintained on ART. So again, ART is very important because it's the one thing that has been causing the epidemic to come down. It's actually a bit surprising that it took us so long to realize that just about everybody should be on treatment, because that will bring the overall numbers down. But that is essentially what has it's done about bringing down the epidemic. We don't have to deal too much with HIV-2 in our country. It's more a problem in West Africa. So it's slower progression. If it's often undetected, and if you don't do Western blot for HIV at the time of the positive ELISA, you may miss it. And if you haven't done a viral load, you may also miss it. The NNRTIs won't work. HIV-2 viral loads are not easy to obtain. The INSTIs work, and some PIs are better than others. So it's actually quite specialized. Fortunately, we don't have to deal with this problem too much. But in some patients who have HIV-2, we have to switch regimes and just go by the fact that the CD4 count is the only marker we have of response. You can see over here that rates of virological suppression can barely be improved further, because all the regimes cause full virological suppression. And most patients in clinical trials and practice who are not suppressed because they're not getting ART. Only a small fraction will have multi-class resistance. So you can't really improve HIV treatment too much more. The current regimes which we have of the triple drug regimes, which we are starting people on with the INSTIs and with NNRTIs are very powerful and effective, and they cause full virological suppression. But despite this, HIV therapy can be improved. And how is that? Number one is that the safety. We want to make sure that when we are giving patients medication, we're not poisoning their kidneys or their bones or their hematological system, etc. We want to make sure that we're not just writing a prescription and packing them off, that they can tolerate the drugs, and the drugs which we give are easy to take, will not have them, wanting to throw them away and not take them, etc. That they're convenient, single tablet once a day, that they're not expensive and they're affordable, that they have activity against a lot of resistant virus, because as things stand, we still do not have any available cure. So if we don't have a cure, we have to give people medication. If we have to give people medication, and it's so important to give them medication because not only is it saving their lives, it's preventing transmission of the virus in the community, then we have to make sure that what we give them is something that they will take and they'll be happy to take. So we have to address all these issues down the road with this. There have been some efforts to understand how we can go about curing HIV, and there have only been 2 patients who've been cured, and that's because they've been given bone marrow transplants with marrow which contains deletions for the CCR5 attachment epitope, and therefore the HIV can't move between the cells. And people have thought of different strategies, which I found interesting, so I thought I'd share this slide with you. It's a complex cure for a complex reservoir, because even though we have undetectable viral load in the plasma, it bounces back because there is latent HIV living in the DNA in cells in a reservoir somewhere or the other. So you need ART to suppress viral replication and debulk the HIV burden. Then you need multiple kick and kill doses to gradually eliminate the latent reservoir, bring the virus out of there. You need to look at block and lock agents, which lock the HIV provirus into a permanently non-replicative state. And you need immune boosting with broadly neutralizing antibody infusions, or these CAR T cells, which they use now in certain malignancies, treatment of certain malignancies, which HIV-specific chimeric antigen receptor T cells, which will go and attack those cells which have HIV proviral DNA, and therefore you actually eliminate the HIV reservoir from the body, which is the key to obtaining a cure. So either you get the reservoir out, or you block and lock it completely so the reservoir can't come out into the blood anymore. So curing the patient is one thing, and curing the epidemic is another thing. The number of new HIV cases are falling as a result of early treatment, because of the fact that we realize that we treat as prevention. You test and you treat. Same day initiation of ARVs is now recommended in the West. We have PrEP, pre-exposure prophylaxis, for people who may be at high risk. And we are now moving out to identify HIV positive patients. They say that almost everybody who's admitted to a hospital or has any significant illness should have an HIV test. And we have almost universal suppression, lower costs, and better access to medical care. So things are moving in the right direction. Certainly, I think as someone who's treated HIV for all these years, it doesn't worry me too much, except when patients are undiagnosed and come very late, because I'm reasonably confident that we will be able to get patients better, which certainly wasn't what the story was at the start of the whole epidemic. Now, of course, HIV medicine has become a very complex subspecialty of internal medicine and, in fact, of infectious disease, because the HIV doctors had to acquire skills as the ID physician initially, dealing with all the different opportunistic infections. He had to be an immunologist to understand about CD4 counts and different T cells, etc. He had to become a virologist to understand a little bit about the virus, a clinical geneticist to understand about the interpretation of genotypic resistance testing, a clinical pharmacologist to understand all these complex drug interactions that take place, which I completely fail on. You need to be a little bit of a biomedical researcher. And now finally, you also need to become a bit of a physician for the elderly and understand things about frailty syndrome, bone density, a declining renal function, cardiovascular abnormalities, etc., etc. So with that, I'll stop and hand it back to Dr. Onkar, and thank you very much for your patience.
Thank you very much, Dr. Jehangir Sorabjee. It was just like a storytelling beginning for 27 years of journey, how you were used to treat 3 decades, and now you talk till the cure of the medicine and what the prerequisite of a HIV specialist. Thank you so much for such a illustrative lecture. So we'll stop a minute and we'll go back to our second speaker, Dr. Rajeev Soman. So those who have some questions, please write down into chat box. We will take the questions at the end of the second lecture. So over to you, Dr. Rajeev Soman, sir.
Can I share the screen?
Yes.
Okay,
sir,
good evening to you, friends, and it's indeed a great pleasure to be on this platform with Emcure, all of you there, and dear Jehangir, it was really it was a wonderful lucid talk, Jehangir. It was you made it deceptively simple. Let me put it that way. You just it was almost like a fireside chat or something like that, but you had literally everything that is there in the updated guidelines and also the history. Excellent. So my brief is a little different, and although Jehangir doesn't want to have anything to do today with COVID-19, I'm going to force something on him today. Okay, and what we are going to talk about is when HIV and SARS-CoV-2 combine forces, things start becoming complicated, they start becoming mysterious. In other words, the plot thickens. And partly for this fun, because the plot thickens. Okay, and I'm going to address this in this issue in this case. So this is a 40-year-old person, obviously HIV positive for 15 years, has been on tenofovir, 3DC and nevirapine. In September 19, his CD4 was found to be 250 and viral load was undetectable. In June, he presented elsewhere with fever, cough and dyspnea for 1 week. His nasopharyngeal swab RT-PCR done ×2 was negative. However, his saturation was 88, CRP was high, LDH was high too. His CD4, which was 250, more or less remains in the same range like 181. But wherever he was being treated elsewhere, they thought this could be ART failure. And this is probably now, since the CD4 has declined below 200, probably this patient has PCP. So he was treated with PMP, SMX, steroids and antibiotics. ART was continued. The patient improved and was discharged after 10 days. A month and a half later, in August, he had low-grade fever, but he had cough, pain and swelling on the left side of the neck and the left arm. They did a CT scan again, and you could see that there are, so some kind of faint GGOs, and there was a right lower zone opacity, which you can see, which is a peripheral pleural-based opacity. And interestingly, there was a thrombus there in the left brachiocephalic vein, as you can see here, and the patient was referred for an ID opinion. So looking at all this picture, it seems that this previous illness may not have been PCP. In fact, it could have been COVID-19 despite 2 RT-PCRs, and this could be a venous thromboembolism, and you could have had the patient could have had a pulmonary infarct. So we did his SARS-CoV-2 antibody, and that was strongly positive. His HIV viral load was undetectable. He was treated with low molecular weight heparin. Nevirapine was changed to dolutegravir, and warfarin was planned post-discharge due to the cost, because we did not, the patient was probably not, would not afford rivaroxaban and so on. So really, what are the issues in this case? So first is that you can have, how good is the RT-PCR, nasopharyngeal RT-PCR for diagnosis of COVID-19? What might be overlapping features, including radiology, of COVID-19 and PCP? What could be causes of thrombosis? Could the correct diagnosis and upstream intervention have actually prevented downstream thrombosis, which the patient had developed later? What about prevention and management of thrombosis? And what about change of ART and some drug interactions? Let's quickly see each one of them. So we know certainly that this is the best test which is available to us, and that's the RT-PCR nasopharyngeal swab. But let me remind you that the sensitivity is only about 63%, and there are very rigorous ways in which this particular nasopharyngeal swab has to be collected. And only when we do that, we can have a good clinical sensitivity of this test. In fact, COVID-19 actually highlights the difference between what is called as analytical sensitivity and the clinical sensitivity of a test. Don't get intimidated by these terms. Analytical sensitivity is simply the ability of the test to detect the pathogen in the specimen. On the other hand, clinical sensitivity is the ability of the test to detect the infected status of the patient. So obviously this will depend upon how the sampling has been done. So it depends on the sampling site, duration of symptoms, disease severity, method of collection, transport, and so many other things. And therefore, really, even when you have this test done twice and it's negative, it cannot always rule out because of these issues. Okay, and in this situation, probably there are two ways in which we can handle this. One is, most of the time the test which is done is not the Expert Express SARS-CoV-2. So this is the Gene Expert platform, and I'll come to that, how it might help in some situations. And of course, serology may help to make the diagnosis in retrospect. So in instances where there is a very low target load, this Expert Express SARS-CoV-2 may detect only N2 gene. Okay, and this is going to be very important because the sensitivity is slightly higher than that of the E gene target. And the manufacturer has fixed the assay termination at 45. In other words, the manufacturer has improved the sensitivity of this test very well. And I have often seen this, that when the test is negative by other methods such as TrueNAT or certain other open PCRs, the SARS-CoV-2 is more sensitive. So this kind of a positive pattern of N2 with negative E is also seen with asymptomatic infections, early pre-symptomatic infections, or in the late phases. Plus, serology comes to our help. So maybe when you do the test 15 days or more later after that putative illness, which could have been SARS-CoV-19, we might get a positive serology, and that might help us to make the diagnosis in retrospect. What about radiology? So we know very well that COVID-19 produces this sort of infiltrate, which is bilateral basal subpleural GGOs. Note that this distribution of these GGOs is completely the reverse of that of PCP. So in PCP, you actually have parahilar GGOs and there is basal sparing. Whereas we know fully well that these GGOs in COVID-19 are much more in the peripheral, bilateral, symmetrical, subpleural areas and much more in the basal areas than in the parahilar regions. Also, lung ultrasound is not commonly done, but it's an extremely useful test which can also tell you what happens in and how to diagnose say COVID-19. For example, one would get a thick irregular pleural line along with these flashlight beams or waterfall B lines, as it is called as. So radiologically, it is quite possible to confuse PCP with COVID-19 in some cases, but as I think that the two can be distinguished with the help of these findings. How do we make a diagnosis of PCP if there is a low CD4, there has been no TMP-SMX prophylaxis as in this patient? So the usual ways, hypoxemia, the high LDH and a LDH to PO2 ratio which is greater than 4.5 can all be helpful. Interestingly, beta-D-glucan, we found it's very often that it's extremely useful. So this is a fungal marker by and large. It's like a pan-fungal marker and it's very high level which comes up in PCP because after all PCP is a fungus. Obviously, it's not specific for PCP. There could be candidemia, there could be others, but in PCP generally you get a level which is greater than 523. So this is really at the upper limit of the test detection. So this is a very valuable test for detecting PCP. Additionally, we are all familiar that calcoflow staining, immunofluorescence, and so on, which are useful in PCP, but some of these have to be avoided in a patient who's having an active COVID-19. PCR from lower respiratory samples is also an exceedingly sensitive and specific test. It is in fact so sensitive that you need appropriate cutoffs of CT values in order to differentiate colonization from true infection. How does HIV lead to thrombosis? And we are familiar with all these mechanisms for the last 20-30 years. So it does produce all these alterations, basically antibodies, endothelial dysfunction, vasculitis, metabolic abnormalities, and Jehangir was talking about all this. The ID physician has to become a metabolic physician with all this. So increased homocysteine as well as fibrinogen. There could be other infections which are also thrombogenic, such as CMV and syphilis, or tumors, and sometimes even boosted PI regimens would increase the prothrombotic state. How does COVID-19 lead to thrombosis? Again, by involving all the elements of the Furcos triad. So you have hypercoagulability, you have endothelial injury, as well as stasis in certain areas of the body. And hypercoagulability is again due to all these factors. There is loss of protective anti-thrombotic activity, and really there is endothelial dysfunction due to the viral infection. We know about the ACE2 inhibitors and so on. And it's actually producing a thromboinflammation, which is characterized by thrombi in situ and not always necessarily emboli. Even in this patient, you saw that there was a thrombosis in the brachiocephalic vein, although probably this fungal pulmonary infarction did occur because of embolism. Extremely complicated chart, but what it tells us is that the SARS-CoV-2 impacts directly the endothelium. It impacts the inflammatory cells such as macrophages, impacts the liver and which produces all these clotting factors. It impacts the neutrophils and as well as the platelets. So finally, you get a microvascular thrombosis on this basis. And I would sort of submit to you that if the diagnosis is made of COVID-19 in time, as perhaps in this patient, whether upstream antiviral or immune modulating agents, if they were used in this patient, would they have reduced the thromboinflammation? Would it have been more efficacious than downstream attempts to suppress the coagulation system, which the patient finally needs to have? So the management is basically, we need to prevent in almost all hospitalized patients, especially those who are in the ICU. And these might be certain factors which I listed here, including an HIV co-infection, which places the patient at risk of a prothrombotic state. And we have these direct acting drugs as well as warfarin, as well as the low molecular weight heparin, which we might want to use. Nobody really knows what should be the duration of treatment, but maybe typically 3 to 6 months might be advisable. Can we have changes in the ART in this particular patient? And are there any interactions? Answer is yes. So warfarin was selected in this patient rather than the others due to cost consideration. And we needed to change from nevirapine to dolutegravir for 2 reasons. One is to avoid the interaction between nevirapine and warfarin, because nevirapine, remember, is a mixed inducer inhibitor. So it induces enzymes, and therefore warfarin becomes less effective. So you really need a larger dose of warfarin for it to be effective. So here in this patient, we elected to wait for about 2 weeks to allow the enzyme induction effect of nevirapine to wear off before starting warfarin. So till that time, we continued with the low molecular weight heparin. Or perhaps we could have used a higher dose of warfarin, but a little dangerous activity. And that can only be done if you have a very careful and intense monitoring of the PT-INR. With this, I'll move on to the next case, and I've titled this case as the lockdown opportunist. So here we have a 58-year-old male patient. He is diabetic and he developed cough in the beginning of April 2020 when the lockdown actually started. So this patient was prescribed steroids by his family physician. Now the cough continued, actually worsened. So what can the family physician do? He prescribed more steroids. By now, the patient started losing weight, followed by drowsiness, incontinence, and expectoration. So his sputum expert MTB was done, which was negative. Nevertheless, he was prescribed HRZD, that is full ATT. Obviously, no improvement occurred in this particular patient, and with this, he presented to us. So interestingly, when he was evaluated, he was found to be HIV positive. His CD4 was just 32 with a high viral load there. And as you can see, this was his expert from the sputum, which was negative. And there were these tiny nodules distributed everywhere, but a very large nodule in the right upper zone, which is already showing some cavitation. Did a bronchoscopy, and interestingly, this was found. So this is a filariform larva of Strongyloides stercoralis, and the stool also showed rhabdiform larvae. So obviously HRZD was stopped. The baseline workup was done for all other opportunistic infections. That was negative. But this radiologic picture of a nodular cavitation just could not be explained by hyperinfection with strongyloides. Now this we know is probably has happened into a hyperinfection because of both HIV as well as the large dose of steroids which was being given to him. But what do you think is unlikely in this patient? Is it not likely to be nocardia and so on? So here, if we look at it, it's really unlikely to be TB. And the reason I'm saying so is that this is a thick nodular cavitation, which is really unlikely with TB, especially in HIV with low CD4. We know that cavitations do not occur, and such a one large cavitary lesion is somewhat less likely. And in the presence of a cavitary lesion, if you have a negative expert, it will really have a good negative predictive value about TB. On the other hand, nocardia is likely. It is correlated with steroid intake, and the imaging features are also consistent, although it's not really very, very common with HIV alone as the risk factor. So if you have added to that steroids, yes. What about aspergillus? Again, almost for the same reason that both of these infections could be there. So the BAL galactomannan was negative. A diligent search of the BAL smear was urged, which revealed this organism, which is gram-positive branching filamentous beaded form of nocardia. And that actually grew on the LJ medium after about 15 days. Once we see nocardia in the lung, we are obliged to rule out a nocardia in the brain. So MRI was done, and that was negative for any mass or a space occupying region or an abscess. ECSF was normal, because remember, we may also have to think of cryptococcal meningitis in this particular patient. CRAG was also negative. So we treated him with ivermectin along with amikacin, Bactrim or TMP SMX and linezolid for this nocardia. However, we could not obtain a pure culture of nocardia, and actually we could not identify its subspecies with the help of Malditov mass spec, and DST could not be done. But the patient on this treatment showed a remarkable improvement. And after a brief delay, we did start him on TAF, FTC and dolutegravir, and the patient did very well with both these opportunistic infections. So the messages from this case are prescribing remotely has its own hazards. Okay, so in these days of teleconsultation and everything else, we are suddenly jolted sometimes by these sort of things. The use of steroids can lead to a lot of opportunistic infections, especially if coupled with another immunocompromising condition. Also, finding one infection should not end our quest. Multiple simultaneous and sequential infections can occur, especially in the immunocompromised patients. And clinical radiologic and microbiologic correlation is very, very important to sort out all these lockdown opportunists. I close with a few thoughts that especially the parallels between HIV and SARS-CoV-2 are somewhat compelling. Both are RNA viruses. Transmissibility is maximum in the pre-symptomatic or minimally symptomatic stage. Both undergo frequent mutations. Both lead to thrombosis, metabolic derangement, and opportunistic infections. In fact, I would go on to say that COVID-19 and its treatment is actually aids in fast motion. I'm sure Jehangir will agree with me that there are so many infections which are acquired by the patient because of the steroids. I don't want to talk about Mucor and other things, but basically even ICU stay, prolonged stays in the hospital, central venous lines, aseptic precautions thrown to the wind, and so on. So all these are creating a lot of other infections, and which are happening very fast. Both these viruses exploit the peculiarities of human behavior and have really spread quickly across the world. SARS-CoV-2 must not make us forget where we have come in our quest to end the HIV epidemic and how it was done. And Jehangir really told us in a very elegant way how it has been done and how it has been transformed into a chronic manageable illness. So all these gains in the HIV treatment should not be lost because of this lockdown, because of interruptions in treatment and so on. And so I will go on to say that we need a good, robust, one world type of response, even against COVID, as has been provided for to a large extent for HIV. And with this, I will stop my screen share and join in the discussion. Thank you.
Thank you very much for these two interesting cases and the discussion around this. So we'll go for the question and answers, and there are few questions which we have noticed. Sir, first question is from Dr. Mamta Lala. So she is asking that when we are seeing a lot of adolescents coming with thrombocytopenia after starting dolutegravir. So can Dr. Jehangir sir, can you just add your thoughts on this, particularly for thrombocytopenia after starting with DTG?
No, I've not come across that as a side effect, and I've not come across any recommendations that it be monitored particularly in the first few weeks or months or whatever. So as far as I know, there's no evidence, maybe just fortuitous that this is happening. I don't know what your what Rajiv's experience is.
Yeah, I have never come across to.
Okay. So thank you, sir. Thank you. So let's move to the second question. So the second question is from Dr. Manoj Pardeshi. So what he is asking is that can patient living with HIV on ART can be shifted to monotherapy? And if so, what are the pros and cons of the monotherapy, sir?
The answer is no. Basically, is that patients who are stable can sometimes be shifted to dual therapy. And what's exciting also is the fact that there are good trials now showing that people can take once a month injectable cabotegravir with rilpivirine, and one shot a month is good enough to keep people well suppressed virologically. But that is also two medications, one INSTI and one NNRTI. So giving monotherapy alone is a formula for creating drug resistance and virological failure, and under no circumstances should monotherapy be used. Single tablet regimes are good. So it's one pill. Monopill regimes are good, not mono drug.
Yes. Sir, you also touched upon the monitoring of patients, because those patients who are taking the medicine for a long duration for renal, bone, and lipid and all infectious monitoring. But sir, how frequently one should look forward for renal and bone monitoring?
It's difficult. My formula is basically once in 6 months. It depends. Basically, most of the times we're looking for problems in patients who are on TDF, tenofovir disoproxil fumarate. And so if they've been on it for a long time, they do develop renal problems, and it's especially magnified in thin women with low CD4 counts. That's the setting for getting renal dysfunction. So we would monitor with just a urine routine every 6 months, and if there's proteinuria or glycosuria, anything to suggest that there's a tubulopathy, then we would jump in and do more tests. But otherwise, if patients are stable, not more than every 6 months, maybe even once a year.
Okay. So maybe I would like to ask from both of the experts and take the opinion of the both of the experts, because in the presentation by Dr. Jehangir, Sorabjee sir has touched about the inflammatory markers, which is very commonly talked nowadays, like ferritin and dimers and all these things. So how you look forward, sir, in a maybe future, it would be a markers which will be commonly monitored, or it has gained just interest because of the background of COVID pandemic, sir? I would like to have opinion from both the faculties.
So my thinking is that basically what is happening is that patients with HIV are being looked at so intensely with so many blood tests that they may actually be having a longer lifespan than normal people who neglect themselves in the West, because that is happening. But essentially what is happening is that having sorted out the problems of the CD4 count and the viral load and the metabolic problems of osteopenia and renal function, etc., people are looking for other things which require correction and modification. One is the fact that there is some low-grade inflammation which is going on in the body because of the fact that there is virus in the body which is multiplying. And there are trials going on to see if the use of statins or aspirin will actually help that, but those data are not available. And currently, it is not recommended that you do tests of these inflammatory markers or put patients on any of these drugs to try and correct them.
Right.
Rajeev?
Yeah, I entirely agree with you because suddenly all these ferritin D-dimer and everything else has come in the consciousness of most physicians. We were blissfully unaware about all these markers all these years, and so now there is a tendency to use it for almost everything. So I don't think that is justified at all. We know certainly that there is an inflammatory state is going on, but actual efforts to find that out, the intensity of inflammation, as well as to try to correct it by whatever treatment is not real. The key to the whole thing is start treatment early and keep it going. That I think is the best way to avoid the inflammatory syndrome in the patient. But we know certainly that in spite of all our best efforts, inflammation is going on, atherosclerosis is going on, and maybe lymphomas and other things are going to be there, which will be important problems for which we just have to keep a surveillance going on.
Okay, thank you, sir. Thank you. So, Dr. Soman, sir, there is one comment and question for you from Dr. Beena Kamble. So she compliments it was very nice presentation, particularly case studies. But at the same time, she was asking, surprisingly, we are not seeing COVID infection in our HIV patients. So any particular reason for that?
I don't know there is any competition between these two viruses and whether HIV fights off COVID-19 in any significant extent. I don't think there is, I mean, maybe this is a personal observation, but I don't think there is any data which supports that in any way HIV patients are less prone to develop COVID-19 infection. And when we say that infection, we don't know how many of them are mildly symptomatic or almost asymptomatically infected. Probably when you are looking at people who are admitted, who come to a lot of medical attention, at that stage we see them. But there might be so many others who are infected without much of symptoms. So unless it is really looked at on a population basis, we can't really make comments on that. So, and there is no mechanistic reason by which the one could be protected because of HIV.
Absolutely, sir. Absolutely. Sir, there's another question for you. So the questioner is asking, can all COVID medications which are used in COVID treatment in HIV patients affect dolutegravir? Or in other words, he want to ask whether the patient can continue the dolutegravir regime despite they are being treated with COVID-19.
Yeah. A very nice question. But the first, my question or a counter question is, which are the COVID medications that the questioner is talking about? Because I don't know whether there are any COVID medications except a little bit of remdesivir or maybe steroids, and in selected cases something like maybe tocilizumab. Okay, so everything else is not really a COVID medication, and then there aren't any particular interactions with dolutegravir. So if the patient is on dolutegravir, he can definitely continue the same. Even if you see lamivudine or maybe TAF or TDF, there aren't any important interactions there.
Okay. Thank you, sir. Thank you. So there's Dr. Jehangir, sir, there's one question for you. It is by Dr. Manoj Pardesi, sir. So dolutegravir DTG is increasing blood sugar and the diabetic condition. What needs to be done to avoid this situation?
I don't know the answer to that. A lot of that is because of the weight gain. There is some interaction with some of the drugs with metformin. But I think that is basically it increases metformin levels and brings sugar down. So I don't, other than controlling the weight gain, and once we get a better grip on what is exactly causing the weight gain, and whether it's the combination of TAF and dolutegravir, or it is just dolutegravir and the INSTIs itself, there's nothing more to do than to continuously monitor the sugar and advise people to be on low carbohydrate diets, exercise regularly, and try and avoid the weight.
Thank you, sir. So Dr. Soman sir, there is one question for you from Dr. Divya. So she's asking, in a post-COVID period, should we see this patient every monthly rather than monitoring them 3 months with ART refill? What is your views on this?
No, not really. From the point of view, if the patient has received ART all through his illness, there is really not much of a chance that something will go wrong with them. And I don't think we need to change in any way. So just continue in the same way that we were doing before, regardless of COVID-19.
Okay.
The patient, because of his COVID-19, he might require monitoring for something else. That might be a different issue, but not because he's co-infected with HIV.
Okay. Sir, in your first case, you talked about very illustratively about the thromboembolic complications associated with COVID-19 and HIV patients. So these patients, they required anti-thrombotic, maybe Novak. Sir,
Yes.
What is your preferred dose for these Novaks, and how long you give these patients Novaks?
See, it depends. Now, each drug has its own different dosage, and we have either prophylaxis or therapy, and probably 3 to 6 months seems to be the time that you should be giving it in patients who have had a serious problem. Means either COVID-19 was serious, or they actually had a thromboembolic event or even thrombotic event. So 3 to 6 months is probably the time.
Okay, thank you, sir. Because this is something which is conflicting. Nobody has a proper people practices separately, differently.
Yeah, but there are important guidelines coming from American Society of Hematology and others, so we can definitely refer to them. They are also not very clear exactly what might be the time point, but 3 to 6 months seems to be very reasonable.
So maybe, sir, there are another 1 or 2 questions, sir. We can just take up before we. So Dr. Prakash Bora, sir, would like to ask the question. Just a second, sir. Give me a second, sir. What are the indications for TAF10 usage, or whether using TAF10 will help to reduce the obesity due to dolutegravir and TAF25?
As far as I know, TAF10 is only used when you've got boosting with cobicistat or ritonavir. And if you use TAF10 just with a regular regime, you will probably get suboptimal TAF levels. And I'm not sure if there's any role for TAF10 in a regular regime. Rajeev?
No. What you said is absolutely true. So it should be 25 plus 200 in a regular regimen. But if you have, particularly if you have double the dose of ritonavir, such as, with maybe full dose darunavir or full dose lopinavir, then maybe definitely it should be reduced to 10. Otherwise, it's not very clear cut. Even if you continue 25, it is not too bad. But why would you want to give a little extra drug when 10 is sufficing? So definitely that is but I can guess from what the question has been asked is about TAF10 for obesity. In fact, it's the other way around. The full tenofovir TDF actually creates some problem and prevents obesity from developing. So if you don't want obesity, you should be actually not on TAF, but on TDF. So TDF DTG produces less obesity than TAF DTG, both in obviously along with impricitabine or 3TC. So there is something which is there, but obviously the renal effects and adverse effects of TDF will probably outweigh this consideration. But really, this is a vexing problem, Jehangir. I'm sure you are also battling with this sort of a terrible amount of weight gain, especially in women and all that. And it just continues. So what are our options if we have this kind of a weight gain? I think there are very few options, because especially if you have somebody who has resistance, if this patient has also NNRTI resistance, then there is no scope for giving NNRTI, which will bring down the chub's weight. So the other alternative is a boosted PI, which also is not a really good alternative in terms of metabolic changes and so on. So we're really stuck with this.
We are helpless, and changing from Initially, I thought changing from dolutegravir to bictegravir might help, but in fact, I think the weight gain is similar with both.
No, it's the same.
It's the same.
Yeah.
So Dr. Soman, sir, there's another question for you from Dr. Manoj Pardesi. So he's asking, can the third booster dose is preferred and helpful in patients with living with HIV?
See, Jehangir's commandment is that we should not be talking too much about COVID-19.
No, please. It's a very relevant question.
See, this is a very relevant question, but I am invoking your what you said because I don't know the answer. Very simply, we don't know whether a third booster dose, very likely it is possible. I don't think there is any harm also in taking, but right now we just don't know. So we have to go by what is the policy and so on.
I think there was something in the press that as of yesterday, the CDC was rushing to give third booster doses to people with immune dysfunction. But I think these are for people who are on immunosuppressives for renal transplant, liver transplant, etc., in whom the doses don't take properly. I don't think it's indicated for the HIV positive population.
Yeah.
All of this is new. We've just had this vaccine for 6 months. It's hardly a couple of months since people have had their second doses. Yeah. So the data that's going to come out is going to take time to come out. And it's not going to be just a measure of the antibody levels in the blood, but it's going to be in terms of real-time data as to, after vaccinating 20 million, how many of the population actually go on to get nasty infections if they're HIV positive and well controlled, etc., etc. So it's going to take at least 6 months to a year before we have a clear answer to that one.
Yeah, because we don't even have a good surrogate marker of immunity.
No. Yes.
All these anti-spike antibodies, and they don't look at the cell-mediated part of it, and
not at all.
And
they fluctuate.
Really knows how to assess whether you're taken it. Correct. See, it's different with, say, hepatitis B. For example, we definitely know our protective titer of anti-HBs is so and so and so on. But otherwise, for others, it's so difficult. And maybe you don't have a good titer of antibody, but after the virus shows up, maybe your T cells will start, telling the B cells to make antibody. T cell responses may be good. Lots of unknowns in this.
Correct. Fortunately, we've got very good analysis of real-world data. So, a country like UK, for example, which is vaccinated massively, and they collect data on everybody. We know that most of the people who are really sick are only the unvaccinated.
Correct.
And that vaccine actually helps very well and is very effective in preventing people from getting sick and into hospital.
True. Even in our country, there have been hardly any deaths among the vaccinated people, even in the second wave.
Correct.
So that's quite heartening to know.
Yes, hopefully we won't have any more nasty variants coming around.
Yeah. So sir, we can get, you can see there's a lot of compliments for your lecture as well as discussions. So that's very nice, sir, because many people have given compliments for excellent talk and the deliberations that we had. So I think we have addressed all the questions, most of the questions. So we can stop here. So before we stop, I would like to my sincere gratitude to all our faculty today night, Dr. Jehangir Sorabjee, sir. Very nicely, you have taken us through all the journey and the history of the HIV medicine like a storytelling, and it was very nice to hear, sir. Thank you very much, and thank you for your comments and the discussions part, which really brings out some pearls of wisdom. That's very important. Thank you very much. I also thank Dr. Rajeev Soman, sir, for presenting interesting cases at a real life scenario to understand how best this can be patients can be managed with the co-infections of COVID-19 and patients living with HIV. And also thank you very much for your comments and the deliberations in questions and answers session. So with this note, let's stop here and we will gather after 15 days. We have another webinar on HIV medicine. So maybe on 14th of August, we will gather again and discuss about with some new speaker, with some new topic. Till then, bye-bye, take care, and have a good time ahead. Thank you. Thank you.
Bye, everyone.
Bye-bye. Thank you. Thank you very much.
Thank you, doctors.
Thanks. Thank you, Dr. Onkar. Bye.
Thank you.